Where the night well. Then if you get to this from them of I don't like water. DJ, come on, have some again. Bring two of your one friends, two of your one friends. I want to give you
I'm telling you.
Good afternoon, everybody. Please, if you can hear me, just react with an emoji. All right. Thank you very much. Good afternoon, everybody. You're welcome to the day 4 of the ECG webinar series that is hosted by the Internal Medicine Interest Group of Nigeria. My name is Dr. Odia Victor, and I'll be the moderator for today's session. So we've had an amazing series so far that has been filled with a lot of practical insights, with good explanations, and with real clinical relevance. And today's session promises to be very exciting. And I hope that we gain a lot concerning mastering the ECG. So to officially begin, we'll take the opening remarks from our esteemed president of the Internal Medicine Group of Nigeria. So I would like to invite him to take the opening remarks.
Your tongue is behaving how, Nikki? How is your tongue behaving? Sorry, Baba.
Hi, please can you mute your stuff here?
Good evening, everyone. A lot of persons are still joining. Let's just give 2 minutes for them to join. Good evening, everyone. My name is Dr. Stanley Okafo, and it's my pleasure to welcome you all to the final session of our ECG training series. Today's session is on drugs, electrolytes, and final review of all what we have been learning so far. From the theme of this ECG training, from basics to life-saving patterns, it has truly captured the essence of what we have accomplished over the past few weeks. We began with ECG fundamentals, and we have truly progressed to recognizing the very patterns that can make the difference between life and death in clinical practice. Today, we bring it all together. This final section is particularly special because it ties up the series, helping us appreciate how various medications and electrolyte imbalance influence the heart's electrical activity and how to interpret those changes accurately. Looking back, this training has truly been remarkable. The consistency, participation, and enthusiasm from everyone have been outstanding. So as we conclude this series, I encourage everyone to remain attentive and engaged, ask questions, share your insights, and let's make this last session as impactful and memorable as others. Once again, I welcome you to today's session. Thank you all.
All right, thank you so much, Dr. Stanley, for that opening remarks. Next on the program, we're going to have the citation of our speaker, which will be taken by Dr. Yahaha. So, Dr. Yahaha, over to you, please.
All right. Thank you very much. It's Dr. Yahya. It's Yahya actually, not doctor. It's still a student. All right. Please, am I audible?
Yeah, you are.
All right. Well, thank you very much. Good day, everyone. I am Imgn Yahya, and it is my distinct pleasure to introduce our speaker for today's ECG program. He is actually my mentor and my teacher, in person of Dr. Fahad Lawal. Dr. Fahad Lawal is a senior registrar in the Department of Internal Medicine at the Usman Danfodio University, Sokoto. He is a member of both the National Postgraduate Medical College of Nigeria and the West African College of Physicians. He is also a dedicated educator, serving as a part-time lecturer too within the Faculty of Clinical Sciences at Usman Danfodio University, Sokoto, and also serve as an administrator, as an instructor for SM Medics. So he's a distinguished alumnus of Usman Danfodio University, Sokoto. Dr. Fahad graduated with his MBBS. Dr. Fahad graduated with his MBBS in 2017, earning multiple awards, including the MDCN's award for the overall best graduating medical student. His professional experience is extensive, encompassing roles as medical officers in various hospitals, and his current position as a senior registrar, where he is deeply involved in patient care and the training of junior colleagues. He also served as an internal examiner for the MDCN Foreign Trained Doctor Licensing Exam. Dr. Fahad is also an active contributor to his professional community, having served as the welfare secretary for the Association of Resident Doctors at Udud, and currently holding leadership roles in the department and academic committees. He was also part of the welfare subcommittee of ASCAR Caliphate 2025, a major scientific event of the National Postgraduate Medical College of Nigeria. His research work includes key areas in cardiology, such as heart failure phenotype and blood pressure monitoring. So please, everyone, join me in welcoming Dr. Fahad Lawal. Please react with your emoji as he takes the stage.
Well, thank you so much, Doctor. Thank you so much, Yahaha, for that wonderful reading of the. Thank you so much, Dr. Yahaha, for that wonderful citation. So it's time for the main highlight of today, the presentation by our distinguished guest speaker, Dr. Fahad Lawal. Thank you so much, Dr. Fahad Lawal, for coming on. Please, everybody, make welcome for our guest speaker.
Okay. Good evening, all. Permit me to stand on the existing protocol. Am I audible?
Yes, sir. Good evening, sir.
All right. So permit me to stand on the existing protocol. First, I want to recognize the effort of the organizers. Just to mention few, Dr. Stanley from University of Port Harcourt and Amir Yahya, one of my mentee, that actually brought me off here today, and many people that have been actively contributing to the success of this webinar series. I would also like to recognize the effort of all the entire community of the internal medicine interest group. As I am an internal physician, so I'm happy to know that people have interest in coming to join us, so that together we can make diagnosis of diseases, we can make impact in treating those diseases, and simplify life and suffering of humanity. I remain Dr. Fahad Lawal. Today we'll be looking at the ECG, also called EKG. We'll look at the electrolyte changes on EKG, drugs, hypertrophy, and we'll take a final review and close this webinar series. It is important you should know that EKG, it is important you should know that EKG is a data. So it's one of the diagnostic tool, a data that you have to know other clinical aspects for you to give that particular data a meaning. It's important to know that I have no disclosures for this presentation. These are my outline. So the heart, as we all know, it undergoes electrical changes. It responds well to electrical activities. And some of those electrical activities are only possible through an action potential, which basically occur as a result of influx and efflux of different ions, both cations and anions across the cardiac myocyte membrane. If you remember that the heart muscles has a unique resting membrane potential of about 96 millimole per liter, so which is a very, just to know that it's in the negative zone, so it stabilizes the myocardium. So for you to have a firing action potential that will bring about contractility of the heart, you must have an impulse that raises this resting membrane potential to up to 0, which is the threshold that will spike the action potential, and it will bring about a contraction. All this occurs at different pace of potassium, chloride, sodium, influx and efflux across the sarcolemmal membrane, which will bring about the obvious contraction and a heartbeat that will eventually lead to pumping of blood to maintain body's metabolic needs. The principal electrolytes that disturbance of them lead to disorganized contractility or actions or conductions of impulses across the heart are mainly potassium, calcium, and magnesium. So what are the disorders of this electrolyte? Generally, disorders of electrolyte is clinically termed as dyselectrolytemia and may be either excessive excitation or an under or a low level of this potassium of this electrolyte. So either of them, whether it is excess in the bloodstream or is low in the bloodstream, is what we term as dyselectrolytemia. So for potassium, which is one of the principal electrolytes that is very important and paramount in different phase of action potential that will bring about cardiac muscle contractility and relaxation, is the first we should look for, which is one of the prototype electrolytes that is important in cardiac function. So hyperkalemia is clinically termed as blood level of potassium or elevated blood level of potassium greater than 5.5 millimole per liter or milliequivalent per liter. Is usually at that level based on the severity. You can have mild, moderate, or severe hyperkalemia. Mild usually within the range of 5.5 to 6.5. Then when it is 6.5 and above, you said it's moderate hyperkalemia. And by the time you have potassium level in the blood of 7 millimole per liter and above, you said it's severe hyperkalemia. There are certain EKG changes when you run them in an individual with hyperkalemia. You may be able to pick that the P wave, sorry. So you can be able to pick that the P wave is widened. All right. So the P wave can be widened. All right, so the P wave can be widened like this. So the amplitude of the P wave generally in the setting of hyperkalemia is reduced and it can be widened. Then there are changes in the QRS complex also. Normal QRS duration, is less than 120 milliseconds, which is equivalent to 3 small boxes on the ECG tracing paper. So once you have elongation by more than 3 small boxes or more than 120 milliseconds or 0.12 seconds, that is what you term as QRS widening. It's also peaked, one of the pictures you see in hyperkalemia. The most consistent feature you see in hyperkalemia is the issue of T wave. If you look at this is a theoretical ECG sheet. So the T wave here is usually tall and tented, like you have a tenting sign. So like you have a tenting sign. So like you have a tenting sign. So like, you know, if you know a tent in the camp, so the tent usually have an elongation. It's like rectangular with a pointed apex upward with and broad base that forms the roofing of a tent. So if you look at this T wave, you can see it's looking something like that. So it's tall and T wave. Normal T wave should be, by most literature, less than or equal to 50% of the preceding R wave. This is the R wave. So you should have at least half of it or 2/3 of it in some literature that should be the amplitude of your T wave. But once you see this T wave, you see it's almost to the same level, and in some cases it can even go in excess or above the amplitude of the preceding R wave. That is what you call a tall T wave. Then this sharp edge that is forming an apex is what you call a tenting sign. So that is also seen in, so sometimes in severe cases, you can have loss of ST segments. So this ST segment will fuse with the QRS complex, giving what we call a sinusoidal wave or S wave that is like a serpentine, like a snake. This is an EKG of a live patient. If you can see here on the precordial lead, you can see the QRS complex is wide, almost 5 small boxes. You can see the T wave is tall. You can see the T wave is tall. Same thing is more prominent as you go downward toward V4, V5, V6. So what is the other potassium disorder? We have hypokalemia. So in hypokalemia, you have low serum level of potassium, usually less than 3.5 millimole per liter. And based on severity, you can have it up to less than 2, less than 1.5 in severe hypokalemia. So notable changes in hypokalemia is ST segment depression. So you can see, if you compare this PR segment, ideally, this ST segment should be at the same level as PR segment. But once you have it below the isoelectric line, that they are not at the same level, you can say this one is a PR ST segment depression. Then you can see the T wave is flattened. In some cases, it can be depressed. Like in this one is severe, it forms a depression. That is the negative T wave. Then the consistent features you may see is the U wave, which is an additional wave in it's usually occur as a result of prolongation or delayed repolarization of the ventricle. Because if you remember, in the basic ECG setting, ST segment and T wave are for ventricular repolarization. So if you have prolongation due to low potassium level, the U wave will appear and become prominent. This is an EKG of a live patient. If you see a lead 2, ST segment is below the PR segment. T wave is negative here. Then you have U wave here. It's very small, like what I told you. It's not as you see it here on the theoretical paper. Then disorders of calcium. Calcium also, you have hypercalcemia, hypocalcemia. Normal serum calcium level is 8.5 to 10.5 milligram per deciliter. In minimal per liter is about 2.12 to 2.25 millimole per liter. Notable changes are the QRS complex is also widened, like in the case of hyperkalemia. Then you have peaking of T wave also. T wave will be projected, but they will not form classical tenting sign as you see in hyperkalemia. Then you can have J waves, also called Osborne waves. However, it's important you should know that this is J wave. Here, J wave, J point is usually the point from the end of R wave to the beginning of ST segment. So within it, when you have a notch like this, that is what you call a J wave or Osborne waves. However, J wave is not only seen in patients with hypercalcemia. Even patients with hypothermia, they can have Osborne waves. That is why we said, and to make a meaning of ECG, you must have a knowledge of clinical setting and you can marry it with the data you have, that is the ECG tracing, so that you can give a diagnosis. You don't use ECG alone to diagnose a disorder. Like in cases of this electrolytemia, you must have a laboratory backup or support of elevated calcium or potassium level, or low level of calcium or potassium. Then you have ECG tracings with all the features we are highlighting, and an individual with or without clinical signs, like in certain of hypokalemia, they can have muscle weakness, fatigue, fermentation, all those things. You marry them all together with the ECG tracing, and you can say this is ECG of a diagnosis is hypercalcemia, hyperkalemia, or hypokalemia, as the case may be. So that is why we said this Osborne wave are not only seen in patients with hypercalcemia, they are also seen in patients with hyperkalemia. Hypocalcemia, typically they have QT prolongation, which we'll discuss more. So if you see, for you to be able to calculate the QT interval, you start from the beginning of the Q wave to the end of T wave here. So the duration is usually 440 milliseconds, in some books up to 460 milliseconds. Anything more than that is QT interval prolongation. However, because the QT interval depends on heart rate, cardiac rhythm, so there is a correction formula, which is the Bazet formula, that you apply based on RR interval distance to be able to correct for it. And so what you use clinically is the QTC, that is this small c indicates corrected QT interval, and that is more sensitive than using raw QT interval, taking the note of rhythm and the rate of heart. Other features you can see, T wave can be tall, and U wave may also appear in hypocalcemia. So this is the ECG level of a live patient with hypocalcemia. If you look at this, the QT interval, you can see small boxes 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So if you have 12, each 12 is 0.04 seconds. At the end of the day, you will have 580 milliseconds. And we said normal QTC is usually 440 to 460 milliseconds. So this indicates QT prolongation. Then disorders of magnesium, this is very rare, usually coexist with disorders of calcium. So when you have hypomagnesemia, you are likely to have hypocalcemia also. So the features are usually intertwined with the features of calcium disorder. So for hypomagnesemia, they may have prolonged PR interval, which is indicated as the distance between beginning of P wave to beginning of R wave here. And you know it's 3 to 5 small boxes, that is 0.12 to 0.2 seconds, or 120 to 200 milliseconds is the actual duration. So when you have prolongation and widening QRS complex with tall T wave, all these features you see, they can also be seen in disorders of calcium. Then they can have ST segment depression also. So what are the drug causes? Now, knowing that electrolyte can affect heart, we should also know that certain drugs can also affect ECG and can also affect heart and can manifest on ECG. There are many toxins that in overdose, they can cause ECG changes, including snake bite. It's one of the venom that is pro-arrhythmic. They can have certain ECG changes for the victim of snake bite, which is a toxin. Then other mechanisms of drug-induced ECG changes include depression of sodium, calcium, potassium, and ATPase, all the ions that are responsible for regulation of this electrolyte. Action of autonomic nervous system. If you know, autonomic nervous system control the sympathetic and parasympathetic activity of the heart through the vagus nerve. Then you have induction of electrolyte changes. Common drugs that are known to affect ECG are digoxin, beta blockers, calcium channel blockers, especially the non-dihydropyridines like verapamil and diltiazem. Common ECG changes in sodium channel blockers, which are mainly antiarrhythmic drugs. One key thing about antiarrhythmic drugs, they are used in treatment of arrhythmias, but they are also pro-arrhythmic. So they also induce arrhythmias if the levels is in excess. They can have, so different changes you can see according to drugs. Some drugs can give QRS widening, some can give bradycardia with wide QRS complex, some can give R wave elevation, some can give right bundle branch block, right ward elevation, VTAC, VFib, asystole, and STT changes. So this ECG, if you look at it, you can see the drug changes that causes QRS widening. If you see from here, this is the beginning of the QRS to the end of QRS. You have how many small boxes? 1, 2, 3, 4, 5. 5 small boxes, which is more than which is equivalent to 300 milliseconds. And remember, we said normal QRS duration is less than 120 milliseconds. So this is a widened QRS complex. So there is important we should discuss digoxin in the setting of ECG. One thing, digoxin is derived from fog global plants. It's called digitalis plant. That is why some people call it digitalis. There are two drugs that belongs to the group, digoxin and digitoxin. They have similar pharmacokinetics with very minimal difference in pharmacodynamic effect. Digoxin is usually used in heart failure with systolic dysfunction. So patient with heart failure with reduced ejection fraction, patient with dilated cardiomyopathy and severe systolic dysfunction, patient with atrial fibrillation in the setting of heart failure all benefit from digoxin. Digoxin has very narrow therapeutic index, and slight changes in digoxin level can lead to digoxin toxicity. So it's one of the drugs that is subjected to close monitoring, and it's one of the drugs listed for therapeutic drug monitoring, that you have to be taking patient sample when they are on these drugs, and you should be monitoring it so that they should not enter from they should not move from therapeutic to toxic level. Virtually, there is no type of arrhythmias that digoxin cannot cause, ranging from ST segment depression, which is known as digoxin or digitalis effect. Look at the picture on this side. The area shaded in red background indicated a reverse tick sign. If you know a tick, it had the cortical has a curve like this. So if you reverse it, you turn it upside down, you can see it will form a depression like this. So this is called reverse tick sign or a Salvador Dali mustache. And this is one of the digitalis effects. Notably, this can be seen even in normal serum digoxin level. Other changes you can see biphasic T-wave changes, T-wave diffraction, and prominent U-wave. They can have bradyarrhythmias, they can have junctional rhythm, they can have bigeminy pattern. Bigeminy is when you have PBCs that are alternating with normal QRS complex. So you have a PBC, then you have QRS complex normal, another PBC, QRS complex. So that is bigeminy, and that can be seen in patients with digoxin toxicity. You can have PVCs, you can have BTAC, VFib. Almost all types of arrhythmias can occur in the setting of digoxin toxicity. However, remember we said this are seen on ECG. You need additional clinical information to know whether so an individual, you must take a drug history that the individual is on drugs or digoxin. You can also take history of dosage of digoxin, how the patient is taking it. You also have to take cognizance of serum digoxin level if you have facility for therapeutic drug monitoring. You also need to do electrolyte assay, especially potassium, because hypokalemia is one of the precipitants of digoxin toxicity. So you also have to screen patient for that. Then you run your EKG. Clinically, individual digoxin toxicity, they can come with GI symptoms, mainly abdominal pain, vomiting, diarrhea. They can come with visual problem, especially yellow halo vision. So their background will be yellow. So they will be seeing most of the things around them as yellowish discoloration. Beta blockers are also drugs that are used commonly for treatment of heart failure, treatment of angina and myocardial infarction. They are also important in treatment of anxiety, certain autonomic system disorders. Toxicity of beta blockers, they can cause nodal bradycardia because they suppress AB node. They can cause heart block, especially first degree heart block. They can prolong fear interval. They can prolong QT. They can cause widening of QRS. They can cause ventricular dysrhythmias, multifocal ventricular extrasystole. They can cause asystole in severe beta blocker poisoning. And so this is first degree AV block. First degree AV block, what notably causes first degree AV block is you have PR interval prolongation. So normally P wave, beginning of P wave, sorry, the imaging is not too good. The P wave is flattened. So this is the beginning of P wave in the 2. Then this is the beginning of R wave. If you can count, you can see almost 7 small boxes here. And we said maximum is 3 to 5. So that is PR prolongation. And the function of PR, if you remember, is the conduction through the AV node. And if you remember, we said beta blockers block AV node. So by so doing, they can prolong the PR interval by slowing down conduction through the AV node. So QT prolongation is one of the things that the drugs can affect. Most of the QT interval, we said, is the beginning of the Q wave to the end of T wave, and we said normally is 0.44 to 0.46 seconds. That is 440 to 460 milliseconds. We said the QT interval depends on the rate and the rhythm of the heart. That is why there is a formula, Bazet formula for correction, that take into note of the rate and the rhythm of heart failure by appropriating the QT interval in the setting of RR interval. Drugs that can cause prolonged QT intervals include antiarrhythmic drugs, most of the antiarrhythmias, tricyclic antidepressants like nortriptyline and amitriptyline, phenothiazines, which are antipsychotics, sotalol, ibutalide, dofetilide, antibiotics, especially macrolide that are used in treating pneumonias, fluoroquinolones used in treatment of pneumonia, GI disorders, urinary tract infections. Other non-drug causes of prolonged QT include hypokalemia, hypomagnesemia, hypothemia, cardiomyopathies, congenital syndromes like Roman-Ward syndrome. They are all causes of QT prolongation. There is an entity called Torsades de Fuentes, which is a French word that is used for twisting along a particular point. So at the baseline, if you see this is an imaging, you can have twist of this QRS complex along the isoelectric line, and that is what you call Torsades de Fuentes. This is occurring when you have a ventricular tachycardia that is polymorphic in nature with QT prolongation. So when you have QT prolongation plus polymorphic ventricular tachycardia, that is what you call Torsades de Fuentes. And it's a very trouble arrhythmia that can degenerate to cardiac arrest and death. However, individual without QT prolongation, you just say they have polymorphic VT. ECG can also be relevant in diagnosing ventricular chamber hypertrophy. And we basically have right and left ventricles. There are changes, the things that can cause changes in the ventricles are mainly pressure overload, either as a result of pressure on the left ventricle or as a result of volume overload. Left ventricular hypertrophy is usually diagnosed by first you look at the Q waves, whether they are there or not. Then you check the ST segment elevation. You can see R wave. Then they can have T wave and inverted U waves. Diagnostic criteria for diagnosing LVH. If you see this fine slide, on your right hand side, you can see an S wave in lead 1. So this is the amplitude of S wave. You count the number of small boxes there up to the apex of the S wave. Then you come to lead 5 or 6 and look at the R wave. So you come and count the R wave amplitudes. So whatever you get here in either B5, B6, you add it off to the S wave amplitude in B1. If it is at least 35 or more than 35 millimeter, is satisfied Sokolo-Lyons criteria. Another thing you can do, you can look at AVL and check R wave amplitude in AVL. So only R wave there, if the R wave is greater than or equal to 11 millimeter, that is 11 small boxes, is also left ventricular hypertrophy. Another criteria, you can use Cornell criteria. Cornell criteria, you look at the AVL and S-wave. So in AVL, you are interested in R-wave amplitude. In S-wave, you are interested in the V3. You are interested in S-wave amplitude. If you count the S-wave amplitude in V3 and sum it up to R-wave amplitude in AVL, if it is more than 20 in women, this one is gender sensitive, you said there is LVH, but in men it must reach at least 28 before you can say there is LVH. This disparity is for the reason that men are likely to be more active, participate in athletic activity, which are all physiological variants that can make their heart to be thicker than that of the females. Romhill-Estes point score system is also important. This one is a bit cumbersome, especially for students, for the resident in the forum. They may decide to use this. There is a voltage criteria, like any of the voltage criteria we mentioned, either Sokolo Lion, Cornell's. You can use any of them. If it is satisfied, you give it 4 in 3. Then if you have concomitant left atrial enlargement on the ECG, which is depicted by predominantly negative P wave in B1, or an M pattern or phi mitrale in lead 2, that is P wave width more than 2.5 millimeter or 2.5 small boxes, that is left atrial enlargement. If it is there, you also give another 3 points. If you have QRS duration more than 0.09 seconds, which is equivalent to 90 milliseconds, that is approximately 2 small boxes, is also 0.1. If you look at the ST strength pattern is usually diagnosed in the setting of LVH when you have slight ST segment elevation with T wave inversion with an LVH. That is what you call LV strength pattern. So if that is around, you can say there is 3 points. If you have left axis deviation, that the LVH occurs with left axis deviation, that is the axis is less than minus 30 degrees, or you use thumb rule and you have predominantly negative R wave in lead 1 and positive R wave in ABF, that is coming toward each other. That is predominantly positive R wave in lead 1 and negative R wave in ABH, that is going away from each other by thumb rule in the left axis deviation, and that is 0.2. Delayed in intrinsic deflection along V5, B6, that is 1 point. So when you summed any of this and the total score is 13, when you have at least 5 or more points, is definite left ventricular hypertrophy using Romhill-Estes scoring system. And if it is 4, you said there is probable LVH. Far less than that, maybe unlikely LVH. Then we look at right ventricular hypertrophy, which you can look at. Usually it occurs in the setting of right axis deviation, dominant R wave in lead 1, which is usually more than 7 millimeter tall, or R over S ratio of more than 1. Then you can have dominant S wave in lead 5 or 6 with R over S ratio of less than 1, then QRS duration of less than 120. And the QRS changes is not due to right bundle branch block. That qualifies for right ventricular hypertrophy. Right ventricular hypertrophy usually occur in the setting of pulmonary diseases, either acute pulmonary diseases like pulmonary embolism, or chronic pulmonary disease like pulmonary hypertension, pulmonary fibrosis, post-TB bronchiectasis, destroyed lung syndrome, COPD, among others. So if you look at this V1, you look at the R wave amplitude here. If you count it, it's almost 15. That is more than 7. And if you are to take R over S, so this is the R wave amplitude, you have about 15. Then you come to S wave on the same lead. Then you count S wave here is about 4 small boxes. Here you have 15. So 15 divided by 4, what can you get? Anyone? 15 divided by 4, what can you get?
3.
Hello?
3.7.
So 3.75. 3.7. That is approximately 4. So you know we said R over S of greater than or equal to 1. So when you have up to about 4, that is greater than 1. So that is in keeping with right ventricular hypertrophy. Next is ECG changes in cardiomyopathies. There are different physiology of cardiomyopathies. You can have a dilated chambers with failure of systolic function seen in dilated cardiomyopathy. You can have a hypertrophic physiology when you have a markedly thickened ventricular chambers in hypertrophic cardiomyopathy. Then you can have restrictive physiology when you can have infiltration within the cardiac muscles that will restrict the relaxation of the ventricles to fill with blood. Hypertrophic cardiomyopathy is one of the diseases that is common. Now there are a lot of researches ongoing with this. Some ECG changes, you can see left ventricular hypertrophy. You can see Q waves that appear like dagger, very pointed end. If you know dagger, those of you that watch Vampire Diaries, there are a lot of daggers there that they use and stakes to dagger the heart of the vampire. So that pointed edge, that is how the Q waves will appear. They may have also inverted T waves. Dilated cardiomyopathy is non-specific. You can see left ventricular hypertrophy, left bundle branch block, arrhythmias like atrial fibrillation, non-specific STT changes. Infiltrative cardiomyopathy, they can have low QRS amplitude. Despite that, on echo, you can see markedly thickened wall. That is a paradox. Then they can have pseudo infarction appearance. That is appearance of Q waves. So look at this. It's more prominent. Look at, can you see V5 and V6? Hello.
Yes, yes.
Yes, sir.
So on
Yes, sir.
B5 and B6, you can see a Q wave appearing here, very pointed. This is what you call dagger-like Q waves. In addition to the LVH, when you apply your Sokolo-Lyon criteria, O'Connell's or Romhill-Estes point scoring system, and you get LVH, then they can have Q wave inversion. These ECG changes in dilated cardiomyopathy, we said is non-specific. You can see they can have PVCs, they can have ST segment depression, T wave inversion. So nothing specific, chamber dilatation. You can have all those ones. So then there are changes of ECG that occur in pacemakers. Individual with heart blocks or conduction disorders. I remember we discussed conduction disorder through these sessions. I think either day 2 or day 3. So all those people with conduction disorders that they develop heart block, either first degree, second degree, or third degree heart block, and they become symptomatic, what we call Stock-Adams syndrome. They are likely to have a pacemaker indication, whether a temporary or permanent pacemakers. So there are different types of permanent pacemakers. If you see, a pacemaker is nothing but just a device that we implant under the skin, usually on the rib cage, below the rib cage under the skin. It has a force generator that contains the battery. You have a lead wire that you place within the chamber of interest in the heart. If you can see, this one is placed in the right atrium, which is an atrial chamber. You can see this one is in the right ventricle, which is ventricular chamber. This one is dual chamber in the right and left ventricle. Then you can have biventricular chamber facing, that is right and left ventricle. In some cases, you can even have 3 chamber, that is right atrium, right ventricle, and left ventricle, and that is what you call CRT, that is cardiac resynchronization, if those leads are meant to be resynchronizing the heart. The hallmark of pacemaker is to recognize the failure in conduction and pace the heart so that it can conduct normally. So because the natural pacemaker of the heart is SA node, so an SA node is responsible for formation of P wave. So where you can see pacemaker changes and pacemaker spiking is along the P wave morphology. So this is where it senses that the normal pacemaker or the SA node has failed, then it will make a discharge and it will create these spikes instead of P waves. Then you can have QRS complex, which indicate ventricular contraction. Then the T wave indicating ventricular relaxation and completion of cardiac cycle. Then another facing another cardiac cycle. So each cardiac cycle, you have a spike in front of or in place of P wave that will generate a heartbeat. This atrial chamber. So the hallmark is to recognize these spikes along the P wave. So let's quickly recap what we did We know that for you to understand ECG, you must put ECG is just a data that contains raw information. It is your obligation as a young doctor, as a medical student, as a young practicing doctor to make sense and meaning out of the ECG tracing. For you to be able to make meaning of it, you need to understand the standardization of the ECG sheet, which we said standard calibration is usually 10 millimeter per millivolt, and also the speed is 25 millimeter per second. The rhythm has to be understood. For you to understand the normal rhythm of an ECG, there has to be a positive P wave. You must have QRS complex preceding each P wave. So each P wave must be followed by QRS complex, then the T wave, then the RR interval is expected to be regular. That is when you can say the ECG has a sinus rhythm, which is the normal rhythm. Then you should be able to calculate the heart based on the setting of the rhythm. And those with normal rhythm, you can just count the number of big boxes in between R to R, that is the RR interval. And if you get it, you divide it by 300, or you can count the number of small boxes and you can say 1,500 divided by the number of small boxes you get. If you have a regular rhythm, you can use 6 method or 10 method second. 10 seconds or 6 seconds method to calculate the heart rate in the setting of a regular axis. The axis, which is mainly the QRS axis, because in advanced EKG, you could understand that all the waves of ECG has their personal axis. There is P axis, QRS axis, and T axis. For student and young practicing doctors, we want them to know the QRS axis, which determines the overall electrical direction of the heart. So for the QRS axis, we say you can use perpendicular method, which is a bit more complex, but the simple method you can use is thumb rule, which can be able to tell you that the axis is normal when you have positively deflected R amplitude in both lead 1 and ABF. You can have a left axis deviation if you have positive deflected R wave in lead 1 and predominantly negative amplitude of R wave in ABF. Then you can have right axis deviation if you have reversal, that is negatively deflected R wave in lead 1 with positively deflected R wave in ABF. Then you can look at the PR interval, which we said is a marker of nodal conduction. And normally PR interval is between 3 to 5 small boxes or 120 to 200 milliseconds. QRS interval is important. We said the normal QRS duration should be less than 120 milliseconds or 3 small boxes. Then you can check for QT interval and corrected QT interval, which we have highlighted. The correction is using Bazet formula, which take cognizance of heart rate and rhythm of the heart. And we said the normal is usually between 440 to 460 milliseconds. Then you can look at the voltage of the QRS complex, which can give you a lot of information. The voltage, you can look at it, amplitude of the bone, you can look at the width, you can look at the overall duration, and you can check whether there is abnormality within the QRS voltage that can indicate the disease. Then abnormal Q waves have to be looked for in ECG. Anything that you are not looking for, you will not see it. So you must be looking for Q waves to be prominent, unless you are sure there are no Q waves. And we said there are certain diseases you can see Q waves like myocardial infarction, hypertrophic cardiomyopathy, restrictive physiology, among others, and certain drug changes like digitalis effect and digoxin toxicity. ST segment changes are also important, especially in patients with myocardial infarction, occlusive myocardial infarction, pericarditis, benign early repolarization. T-wave changes, very important also, can tell you a lot of cardiac and non-cardiac information, including electrolyte. Then U-waves, very prominent in the electrolyte disorders like hypocalcemia, hypercalcemia, and hypomagnesemia. Then you can have precordial R-wave progression, which we discussed in one of the webinar series, as R-wave progression can be early or late transition. But 4-R-wave progression can be normal in elderly people, but usually it's also seen in patients with infarction, occlusive myocardial infarction, OMI. Okay, so now we have teasers. This is going to be an interactive that I want you to discuss with me. So if you know the answer, gently unmute yourself and make your comment and contribution. So we have a 65-year-old banker who presents to the ER with 2 hours history of severe chest pain, diaphoresis, not responsive to his usual antacid preparation. He is a non-hypertensive for 10 years and unconfirmed acid peptic disease, meaning he has not done endoscopy to confirm the acid peptic disease. He also smoked for 20 pack years. You requested an EKG when he arrived, which was depicted above. What is the most likely diagnosis? So how I want you to do is to tell me the abnormality first, then you tell me your conclusion as the diagnosis. So do I have a volunteer for this ECG?
Yes.
Yes,
Yes,
All
sir.
right. What is your,
there
say
are
your name and your center. One person.
Okay, sir. Okay, sir. Name is that.
Your name
My
is?
name is Abdullah Babayo from Byron University, Kano.
Okay, that is great. Fine. So what are the abnormalities on this EKG? Remember, I told you ECG is just a data. So that is why I give you clinical information. So you interpret it in the context. You don't look at ECG in isolation, please. I keep emphasizing, if that is the only take-home message, PCG is a data that you need clinical laboratory support for you to interpret it in the context and make a sensible diagnosis. All right, so Abdullah Babayo.
Yes, sir.
All right.
I can say from lead one. From lead one, sir.
Yes.
It is obvious the ST segment is low. From the
Okay.
isoelectric line.
So why do you say is low? That is depression, right?
Yes, sir.
Why do you say is low? Are you seeing my pointer?
Yes, sir. If you check the isoelectric line from the
Okay, this is the isoelectric line, right? PR interval, right?
Yes, sir. So
Okay,
the
fine.
ST segment below
so
it.
if we trace it, is lower,
Yes.
right? Okay, fine.
Yes.
Correct. Any other thing?
Yes. Then the at ABF.
Okay, ABF. What happens here?
Yes, the P wave.
Okay, this is the P wave, Abi.
Like it's M shape.
The P wave here. Well, I disagree, Bakani.
Oh.
All right. So any other thing you have seen?
my
Any other
question.
thing you
hello.
I want you to finish so that I can
Hello.
give someone to
It's
also
my
make his
Hello.
input.
It's my cardiac
Am I
infection,
audible?
sir.
No, you can't say. You have to tell us what are the abnormalities. I told you must get the tracing must make the meaning to you.
Then the equivalent
Hello.
complex
Am I
is
audible?
short. It's short.
Hello, sir.
What?
The QRS complex is short.
QRS complex. So where is the QRS complex?
In lead one also. In lead one.
In lead one. Okay.
Yes, sir.
What else
It's
have you
short.
seen? Your eyes, what has it seen?
Yes, sir. Then, sir, actually,
All right. So any other person that want to conclude, you have done well. You have done well, Abdullahi.
Yes.
I will send you a
Yes,
bottle of Coke
Yes, sir.
to AKTH.
This,
All right.
this Dr.
Who wants to
Ikenna
try?
Adana. Hello, sir.
Yes,
Hello.
your name?
Yes.
Your name?
Am I audible?
Kochi.
Sir, my name is Mansoor. I am from Pakistan.
Okay, good.
Sir,
All right. So what are the
as far as,
abnormalities on this EKG?
sir, as far as this ECG is concerned, if we look at the inferior leads, lead 2, lead 3, lead AVF, there is ST elevation greater than 1 small box, along with the reciprocal changes in the lateral leads. So based on these findings, I can say that this is inferior wall MI.
Yes.
Okay, you said there is inferior wall MI. That is very correct. So what is your comment about what Abdullahi, because Abdullahi is also correct that in lead 1, there is ST segment depression. So what is your resolution?
That is reciprocal changes.
Good. God bless you. What is your name? Who said that?
Adana Ikenna Daniel.
Yes, Nathaniel. You are from where?
I'm from Lagos, Greek specialist
Good,
hospital.
very good. That is reciprocal changes. There is what we call, how to remember it, PAIL. P-A-I-L. PAIL.
Yeah.
Posterior wall infarction will give reciprocal changes in anterior lead. Anterior wall infarction will give reciprocal changes in inferior lead. Inferior wall infarction will give reciprocal changes in lateral lead. So if you see here, we have inferior wall infarction and lead 1 and AVL. Come to AVL, you also see the same thing, ST segment depression. Can you see it? Look at the PR segment here. Look at it. Can you see?
Yes, sir.
Yes, so these are lateral leads. So that is where you see reciprocal changes. That is not the infarcted area, but the ischemic area, because collaterals are trying to supply this area. And you must know that lead 2, 3, and AVF, they represent inferior wall. Lead 1, lead AVL, plus B5 and B6, they represent lateral wall. Then lead V1 and V2, they represent septal wall, and V3 and B4 represent anterior wall. However, if you have extension of infarction from V1 down to B4, you can just say it's anterior wall infarction. Sometimes if you say anteroseptal wall, is still affected. Are we together?
Yes, sir.
Are we
Sir,
together? All right,
could
so
you,
well done all. Well done all. Any other question or comment on this before we move from this ECG?
sir,
about
Yes,
lead
there is
3.
also a left
I have
axis
something to say.
deviation.
Sir, can you
There
can you
is
comment about that
The
pale
left
pale
axis deviation.
the what?
No, I don't think
that
There is
so.
that
the
pale
left axis
explanation
deviation.
posterior?
Okay, the fail. I say fail is a way to know where you should look for reciprocal changes. The P, posterior wall infarction, the reciprocal changes manifest on anterior wall, PAIL, P-A-I-L. Then the anterior wall infarction, reciprocal changes will occur in inferior wall. The inferior wall infarction, like in this index ECG, reciprocal changes will occur in lateral wall. So if you see where you have reciprocal changes is lead 1 and AVL, which are the lateral lead. Okay, so let's have a look at this. So this is another question. 50-year-old woman presented with chest pain for 3 days. She has mild shortness of breath. She had flu-like illness 1 week ago. Pain improved on leaning forward and not responsive to antacid. Her cardiac troponins, when done from the laboratory, were marginally elevated. ECG requested was shown above. What are the abnormalities and what is the diagnosis? Any volunteer?
Yes, sir.
Hello?
Yes, sir.
Volunteer? Yes, okay, go ahead. Your name?
My name is Tochi from
Uche?
University of Port Harcourt. Tochi.
From Port Harcourt. Good.
Yeah. Okay. I
So,
see an ST elevation in
ST elevation where?
lead V2, V3.
Please, can you speak a bit louder? In where?
Lead V2.
V2. Okay. For here, right?
V2. Yeah. And V3.
Okay. Any other thing?
Yes. And V3. And V3.
V3 too. So if you see this isoelectric line PR segment, ideally ST segment should be at the same level. They should be at the same level. But this is elevated, right? This is elevated.
Yeah.
Anywhere else?
No. Does V2, V3?
Yeah, it's V1.
Okay, anyone with 3
AVL.
eyes, anyone using spectacles?
There is
Eyeglasses to see
ST
more.
elevation in V1. There is ST
What?
elevation in lead 1 and AVL.
Okay, lead 1, ST elevation, good. AVL, ST elevation, good. Any other thing?
There's a bit of ST elevation
V5,
in
V5,
Please, if you want to talk, tell us your name. We want this way. We want to be organizing webinars actually. So we'll be finding time to organize webinars, not necessarily only on ECG, across medicine generally. So you should know each other so that you can be sharing knowledge. So your name and your center.
Hello. Hello.
Yes.
Hello. Yeah, this is
Yes.
Dr. James Nelson Okema.
Okay.
Yeah,
From
I'm all the way from Uganda.
good.
Yes.
Good.
So what I'm seeing right now in this ECG, I'm seeing almost all the leads that are showing ST elevation. If I'm to be specific, it's
Great, James. Great. So they are all showing. If you look at lead 1, there is ST elevation, lead 2.
Yes.
Lead
So
3.
they're showing actually what we call the concave ST elevation without no reciprocal
Yes, look at the
changes.
ST elevation. Look at it as it is coming. It gives a concave depression downward.
Yeah, so this is a case of
Like a
pericarditis.
scoop, right?
Yes,
Like a
concave
scoop that
upward.
used to fetch water. Or soof.
Yes. Yeah, it's
So
concave
good.
upward.
Any other thing that you see, James?
Yeah, I was saying without no reciprocal changes.
You already end bottle of Coke. I will see how to ship it up to Uganda for you.
Oh, thank you so much. Thank you so much. I'm so privileged to be here.
All right, so fine. Any other thing you have seen?
I know. I was
So if
just
you
saying
look at precordial lead 2, there is ST elevation all through, everywhere. Okay. So any other thing that you see, just say one more thing, just one more. Okay, let me help you. What happens to PR segment?
Oh yeah, PR is depressed, I think.
Is depressed. Yes, PR is depressed. If you look at the ST is going up, PR is down.
Yeah.
So why do you think in this you have ST segment elevation that is limited to some lead while other leads are normal? While here you have ST segment elevation that is widespread, irrespective of whether it's limb lead or it's precordial lead. What do you think happens? Okay, who wants to try? James has tried. Even if he did not answer this question, his sins are forgiven.
Pericarditis.
What? From pericardium, yes, because if you know pericardium is covering the heart. So once you have inflammation of pericardium, all leads will be affected. While in here, you have infarction. So it's only the vascular territory that is occluded that will show changes. Do you understand the reason?
No, sir.
Yes,
I said in infarction, you have an occlusion of single vessel. In pericarditis is a covering, it's like a sac that covers the heart. If it is inflamed, you have widespread changes all around. So
Yes,
that is
sir,
why
yes.
here, only the affected area, the infarct-related arterial territory is showing elevation. While here, all through, because it's coming from pericardium, not from heart, is showing showing elevation. And classical things you see in pericarditis is widespread concave ST segment elevation, widespread with PR segment depression. And if you look at the clinical scenario, we said always ECG should be interpreted in the setting. Clinically, this woman come with chest pain, which MI can also come with chest pain. But if you see a catch here, this chest pain improves when she leans forward. Which pain that improve of a leaning forward? Pericardial pain, right?
Pericardial pain.
Yes. And another catch is this woman had flu a week ago. So which type of pericarditis is she likely to have?
Viral pericarditis.
Viral, yes. Viral pericarditis. So this is how to interpret ECG. You must look at the clinical context, then you interpret it. Okay, so next ECG. This one is that of a 50-year-old man with diagnosis of heart failure and reduced ejection fraction. His estimated ejection fraction is 28%. He was released and placed on medication, including furosemide 40 mg 12 hourly, empagliflozin 10 mg daily, captopril 12.5 mg BD, digoxin 1 mg daily. He presented a week later with palpitations and diarrhea. An EKG done requested above, as shown above. What is the abnormality and what is the diagnosis? Who can talk to me?
Good evening, sir.
I need step analysis, systematic analysis of this question. Everything analyzed. Who wants to try?
Good evening, sir.
Good evening.
My name is Chama Ode from Ebonyi State.
Very good. You are welcome, Ms. Shama.
Okay, so I can
Yes,
see
go ahead.
I can see the scooped ST segments, the digitalis effect in lead 3.
Okay, scoop ST segment, where, and where?
I can see it in lead 3. I can see it's in lead 1, 2, and 3. It's prominent in lead 1, 2, and 3. Leads 1, 2, and 3.
It's prominent where?
Leads 1, 2, and 3.
Lead 1, that is the limb lead, right? Lead 1.
Yes.
Lead 1 is looking a bit innocent here. But lead 2, you are correct. There is some changes there. Lead 3,
And
too.
lead 3.
This is a tracing lead. You know, there is a rhythm strip. Usually we take lead 2 and paste it out so that you can use it for all your calculations.
Yes.
So any other thing? You are doing well. You are doing great.
I can also see I can see some changes in V6, although I can't really remember what it is exactly.
Okay, V6, V6. This is V6. Okay. Okay. So now these changes that you have seen, can you read the clinical scenario and tell us what do you think is responsible for these changes?
Okay, so I believe due to digoxin, which has been prescribed to
Why?
him for his heart failure, he's going through digoxin toxicity.
Why?
He's taking 1 milligram daily.
Okay, so what is the recommended dose for digoxin per day?
I'm not so sure, but I know that 1
Anyone
milligram
in the
is toxic.
forum? Digoxin, how much do we give? Usually maximum in a day. So you believe 1 milligram is too high, Abi? So this person
Yes,
met one malignant house officer, and this house officer give him digoxin 1 milligram. So usually we don't go beyond 0.25. So you see, it's almost times 4 of the therapeutic dose.
Okay, sir.
Abi?
Yes, sir.
Yes. So there is error in dosage of digoxin. If you look at it, is there indication for using digoxin? Yes or no? Anyone, the class?
There's indication.
Yes,
Why?
There is indication
sir.
for heart failure.
Yeah, the patient has systolic dysfunction, so ejection fraction is low. So that there is indication, but the doctor erroneously give overdose. Abi, is one malignant house officer that did not attend ECG webinar. He gave 1 milligram. Okay, so there. All right. So that is correct. So now, based on what we discussed today about the digoxin toxicity, these changes in V2, lead 2, lead 3, you can see it's also there in AVF. If you come here, is there, especially in V6, V5, and V4 at least. So what are these called? You can look at the reading strip. It's so prominent. It outline it for you. There is no ST segment elevation here, Abi, and no clear depression, because where the ST segment starts is usually almost at the same level as the PR. interval. Koba Hakaba. Hello, is that not so?
Yes, sir.
All right. So if you look at this, what does this look like that we discussed not long ago?
Digitalis
Okay,
effect.
fine. I'm coming.
Yeah, autic.
I'm coming. I'm coming.
Husky appearance.
You are taking us back. You people are becoming malignant.
Thick and
All
beard.
right, so look at this.
That reverse thick.
Yeah, can you see the picture shaded in red?
Yes.
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 So just look at it very well. You can see no ST segment elevation, no depression, but look at it. Can you see?
Yes.
Salvador Dali mustache. All right. I'm coming. Fine. Are they similar with this?
Yes.
Yes, sir.
Yes, sir.
So this is digitalis effect, Abi?
Yes, sir.
Yes, sir.
Yes, sir.
Fine. So it's a pointer. You can see P wave is not even there, right?
Yes.
Yes,
Yes,
sir.
absent field.
Remember we said the
Yes.
digoxin can cause virtually any type of what?
Arrhythmia.
Arrhythmia. Yes. So any changes in the setting of digoxin can be. So, but the classical what we want to highlight is the what? Is this a reverse tick sign? So what do you expect? What do you think is responsible for this palpitation and diarrhea?
The diarrhea is one of the side effects of the
It can affect GIT.
Yes.
It can affect GIT. So is it possible that this patient can have ophthalmologic issues?
Yes.
Yellow
Yellow eye.
Yellow.
Yes. Among the digitalis agent.
Yellow vision.
Okay. Okay, so now this one is not part of the question. How will you treat this young lady? Oh, she's not young, she's middle-aged, she's 50.
Okay, so you give Digivac.
Okay, so if you want to give, what is the first thing you do?
You stop the digoxin.
Yes, God bless you. Because if you are giving Digivite and this woman is still taking 1 milligram. So any toxicity, the first thing you do if you are asked a question is withhold the offending drug or agent or eliminate source of exposure. Okay, this is a 35-year-old athlete who suddenly collapsed during a 30-kilometer race and was quickly rushed to a hospital. His father is a renowned footballer, died suddenly at the age of 40. His EKG was requested by the emergency response team and as shown above. What is the most likely diagnosis? Who wants to try? Anyone from Cameroon here? Anyone from Mozambique? Anyone from South Africa? Kampala, Kenya? Okay. Who wants to try?
Good evening,
Nigerians.
Good evening, sir.
Good evening. Who is speaking?
This is Obani Jesu from Obafemi Awolowo University, Ile-Ife.
Ile-Ife, Abi?
Yes, sir.
Oshun. Yes. You say
Yes,
your
Osun
name?
State. Obani Jesu.
Okay, very good. Okay, so please, you have the floor.
Yes, sir. I noticed dagger key waves in V5, V6, and V4.
Yes. Dagger Q waves in B5 and B6. Yes.
And,
Yes, very good. Very good. So what
I
does
also
this
noticed
support?
it in lead one.
Lead one too. So what does this support?
Yeah. This is going to be hypertrophic cardiomyopathy.
Hypertrophic cardiomyopathy. So does the clinical scenario help? How does the clinical scenario help you?
Okay, he has a family history
of
sudden cardiac death.
Yes, sudden cardiac event. people with hypertrophic cardiomyopathy, they usually have a family member that dies suddenly, either from fatal arrhythmias or from an event.
And sudden collapse too.
What?
So
You also have
sudden
an
collapse
activity-related event,
from
right? Activity-related event, right?
yes, be from syncope.
And he's a young man. Who is there speaking Hausa? Mute your mic. Is Abdullahi right? Okay. So next question is that of a 45-year-old woman who had recurrent syncope and palpitations, diagnosed with complete heart block, and was treated 6 months ago. She presented to cardiology clinic for follow-up. She had an EKG and it was shown above. What is the abnormality and what is your diagnosis?
Okay. There's a pacemaker rhythm.
Pacemaker rhythm. Where?
Lead 2.
Okay, let me go to lead 2. Where should I be looking for? Around lead 2 where?
Lead 2 after the
Here?
after the T wave.
Here, this one is what?
This is the T wave.
What is this?
QRS complex.
Okay, this is what?
The pacemaker
Okay, so what should have been here?
a P wave.
P wave from
the SA node.
From the natural SA node. That is the natural pacemaker. So now you have an artificial pacemaker pacing the heart. So you have a spike. You see it spike, then it gives QRS complex and T wave. Another spike for next cardiac cycle. Another spike for next cardiac cycle, like that, like that, like that. Is it clear for everyone? And if you look at the clinical scenario, how does it help you?
She had a complete heart block.
Yes, which is an indication for pacemaker, right?
Yes, yes. And so she came for follow-up.
Yes, so they did ECG to interrogate the pacemaker. That is what we call pacemaker interrogation. All right, so now the floor is open for questions, contributions, criticisms, corrections, and interaction. I hope you enjoyed today's session. I hope I was able to make a change, no matter how little it is, in your lives regarding EKG.
Yes, sir. You have done justice to this topic, sir.
All right, so questions?
Okay, thank you very much,
I
sir,
have a
for the
question,
lecture.
Thank you.
Okay, I'm Shaguzim from Nandazikwe University.
Good.
Anambra State.
Good.
In the second practice question, I want to ask a question.
Are you in clinic? Are you in Inewi Teaching Hospital?
Yes.
What level?
600.
600. Do you know Dr. Philomena Ekemisi? Reverend sister? There.
No, the name does not look familiar. I may know the face, but not the name.
Yeah, I thought she used to dress in Reverend sister. She's a very good friend of mine. We met in Abuja recently for a conference, but we have been friends for long.
Oh,
all
okay.
right. So that is, by the way, in case you see her, tell her that I'm greeting her from Sokoto.
Oh, okay. No problem,
Yes.
sir.
Fine.
Yeah. In second practice
And if you want to reach me, she knows how to reach me. She has every detail of mine.
All right.
Okay.
All right, sir. Yeah. In the second practice question,
yes.
I want to ask: was there no like biphasic T wave there in that second practice question?
Okay, let me go to the second practice question. This one.
Yes.
Mm.
In the V2 lead.
In V2.
In the V2, yeah, in the V2 lead, yeah.
Mm.
The T wave, what do you have to say about it?
the T wave is going towards peaking. It's because it's very prominent. Look at it. It's almost to the level of the R wave, or you can call it tall. If you compare it to the R wave amplitude. I told you normal should be less than 50% of the preceding R wave, right? In some
Yes.
books, two-thirds. So you see they are almost the same level. So it's tall. Which one of the markers of pericarditis, they can have tall T wave also. So they can have tall T wave. They can even have inverted, depending on the phase of pericarditis, they can have inversion before recovery. So initially, when there is pericarditis, acute phase, ST elevation, PR depression. Then as the time passes by, they have tall T wave. As the time passes by, within weeks of pericarditis, they have T wave inversion. Then during recovery phase, the T wave inversion will resolve and they have normal T wave. So pericarditis mimic myocardial infarction, occlusive MI, except that if you look at the MI has obvious risk factors. Somebody will be in his middle or late age or older age. There are presence of comorbidities like hypertension, diabetes, cigarette smoking, significant alcohol consumption, sedentary lifestyle, obesity, metabolic syndrome. If they are young people, cocaine abuse, amphetamine abuse, genetic abnormalities like thrombophilias, hyperhomocysteinemias, disorders of methionine disorders. So all those things, the risk factors must be obvious. But the ECG changes, they can have tall T wave inversion, ST segment elevation limited to a particular area, reciprocal ST segment depressions. But if you look at this one, you have widespread PR interval, and the ST elevation is concave, is concave upward, not convex. Then, so in MI, you have convex. Instead of this depression, it will be what? Outward like this. Vexing. So because it's infarction, it is vexing, it's causing more injury. So you remember it as convex ST segment elevation. It's vexing. So that is how you can remember them. And the ST segment changes is more widespread in pericarditis than in occlusive MI or MI. Then they can have T-wave changes also. So yes, there is T-wave changes. It's also seen in pericarditis. That's why pericarditis clinically and an ECG may be similar, maybe a good differential diagnosis to occlusive MI. Have I answered your question?
Yes, thank you very much. Just that it was not
All right.
pointed out when the abnormalities was being identified. That's why I asked the question.
It's all right. It's all right. Thank you for that addition. Good. Any other person with question?
Good evening, sir.
Yes,
Yes,
Good
sir. Good
evening.
evening, sir. I have a question,
Good
sir.
evening.
Okay.
Yes, go ahead.
Okay, sir. My name is Sawano, and I'm from the University of Lagos. So,
Good.
I wanted to ask a question. So, if we're looking at an ECG and I see an ST depression in the V1 to V4, how would I tell whether it's a standalone non-ST elevated MI of the anterior wall, or if it is a reciprocal ST depression due to a posterior wall STEMI?
Okay. Very good.
Okay, sir, please, I want to say something. There has been a question in the comment section. So
Okay, sorry, I didn't check. Maybe I
yeah,
will assign where is Stanley. You will read out the questions.
no,
But
it's
let
not
me
a
answer
problem.
her first before you
Yeah,
read out the questions.
yeah, it's not a problem at all. After you answer, I'll just read out the question for
So
you.
somebody should just read the question one by one. Okay, so thank you. If you want to see the reciprocal changes here, lead 1, lead AVL, almost everywhere else you can see you don't have significant. So what you should do, if you have ST segment depression, that is NSTMI, what we call NSTMI, usually you will see the area affected will have ST segment depression. Like, let's say this 2, 3 ABF are normal. Then you have this V2, you can see depression, right? You can see depression in B3. You can see some level of depression in B4. Then nothing here. So once you don't have, because TMI is the most severe form of myocardial infarction. And usually, if you have it, that is where you should focus on, because it's a transmural infarction and can be associated with catastrophe. So in myocardial infarction, any arterial territory that shows ST elevation, that is the primary area of focus. So you should look for the reciprocal changes. Like here, this patient possibly can have some you know what is responsible for NSTMI is subtotal occlusion. What is responsible for STMI is complete occlusion. So maybe if you have 90% occlusion here, 85%, 80%, you can have NSTMI. And the same risk factor that give you OMI, that is occlusive MI, is the same risk factor that in other arteries is causing building up of blockage. So it's possible that in this patient, he has this complete OMI here, he has reciprocal changes in V1 and AVL, then he has some subtotal occlusion in V2, V3, and V4, that is anterior wall. So the only way you can diagnose it if you go for angio and intervention. The inferior wall, which is supplied by which artery? Which artery supplied inferior wall?
Right coronary artery.
Yes, RCA. So you see 100% occlusion here. Then you can see 80 to 90% occlusion in anterior wall responsible for these changes. Is that clear? But if you have only these without ST elevation, then this patient has anterior wall and STMI. Are we together?
Oh,
Yes,
sir. So, sir, yes, sir. So, sir, sorry, sir. I was wanted to clarify. So, if the patient has just, for example, in this patient now, if this patient has just ST depression in the anterior leads, then we'll just say
Yes.
they have
Anterior
NSTMI,
wall
and we may
and
not
STMI,
see
yes.
anterior wall NSTMI, and we may not see any reciprocal changes in the
Yes, you may not see, it doesn't cause reciprocal
posterior lead.
changes. Yes, it doesn't cause
Okay,
reciprocal
sir.
changes. It's the full
Okay,
infarction
sir.
from complete occlusion that gives that.
All
All
right,
right.
sir. Thank you
So
very much,
please,
sir.
someone should read the chat box.
Okay, sir. The person is saying you have two questions, sir. So the first one is that you should shed more light on the scenario with sudden cardiac death. And the second question is for the mnemonic for PAIL to be repeated.
Okay. So for the mnemonic
Yes.
of PAIL is posterior wall infarction causing anterior wall reciprocal changes in the anterior lead. Anterior wall infarction will cause reciprocal changes in inferior lead. Inferior wall infarction will cause reciprocal changes in lateral lead. So what are these leads? Anterior lead are V1 to V4, which includes septal leads among them. That is V1, V2 is for septum. You know, ventricular septal wall is part of anterior wall of the ventricle. Inferior wall is lead 2, 3, and ABF. Lateral wall is lead 1, lead AVL, V5, and B6. Posterior wall is you must have extension of additional lead. You must have extension of additional lead. That is lead 13, lead 14, lead 15, usually posteriorly to pick it. Then you can have right ventricle where you can put V2R and V3R and B4R. So the point you put your V3 and B4 on lead placement on the chest wall, you go opposite it on the right side and put an additional lead. And those are the B3 and B4R. Those one will pick the right ventricle for you. But the standard twin lead ECG is only able to show anterior, lateral, and inferior wall. It doesn't typically cause posterior wall changes except you have extended it by at least 3 more leads, that is 12, 13, and 15, 12, 13, 14 to 15. Is that clear? Then for the question with sudden cardiac death, I think he's talking about question of hypertrophic cardiomyopathy, which we said, if you look at the scenario, you can see the man is a young man. He's an athlete. He collapsed during activity, 30-kilometer race. He has positive family history of an athletic father that died at a relatively young age, 40 years. Then EKG shows dagger size hypertrophic cardiomyopathy. So we said hypertrophic cardiomyopathy, when it's on, apart from the diastolic dysfunction, the main cause of mortality in them is that they don't tolerate exercise. So they can develop very fatal arrhythmias, either sustained ventricular tachycardia or even ventricular fibrillation, and they can cause sudden cardiac death and cardiac arrest. So it's the disease that predisposes this individual to sudden cardiac death, not that he has any other thing. So any other question?
Yes, sir.
All
Good
right.
evening, sir.
Good evening.
My name is Adekunle Barakat from Olabisi Onabanjo University. So my question is about the last question, which was about the pacemaker. So I want to ask that, can you identify the chamber in which the pacemaker was inserted from the EKG? Is that possible?
Well, on EKG, it's fairly difficult to identify. Sometimes in advanced ECG class, if you come for advanced cardiology, for those that specialize in electrophysiology, which is subspecialization in cardiology. So those people, they can be able to have some changes that can indicate this is an atrial pacemaker, ventricular pacemaker, single, dual chamber, or even CRT. You can be able to. But what is more reliable to check for pacemaker rhythm in identification of lead and adequate lead placement is either you do fluoroscopic study for the leads or you do an echo to identify those leads. But the best thing is to do fluoroscopy so that you can see each of the leads where it is located. ECG is a 4 indicator for localizing the pacemaker location.
All right, thank you, sir.
Thank you.
Okay, sir.
Any
You
other
have another
question?
Yes, sir.
James, you
another.
didn't send me how to send your cock to you to Uganda. Yes?
You have another question. So
On the chat
person is
box?
asking, yes, from the chat box.
No
Can I
problem.
have pathological Q wave even if the patient does not have myocardial infarction?
Can what?
You have two questions, sir. The first one is,
Yes.
can I have pathological Q wave even if the patient does not have myocardial infarction? And the second question is, what is asystole and what does it denote on the ECG?
All right, good. Fine. So thank you for the question. For the first question, the issue on pathological Q wave. Pathological Q wave, as the name implies, they indicate pathology. Yes, you can have Q wave without pathology. You can have Q waves without pathology, but pathological Q wave is usually in the setting of pathology. And once you have Q waves, they appear in MI, they remain there for life. Even so, that is why one of the things you do to screen previous or old myocardial infarction is by checking for the
Ask him
Q wave.
what we should do about the test. This test was
However,
supposed to be
there are
yesterday.
certain. Hello, am I audible?
Yes, sir, we can hear. Yeah, we
Okay,
can
like
hear you,
someone
sir.
is talking on the background.
Please, can you mute your speaker? Can you mute your microphone?
So there are Q waves that are adjudged not to
We can't hear, sir.
Sir, we can't hear you. Hello, sir.
I don't know. I don't know if you was muted.
Hello, sir.
Hello, am I audible?
Yeah, we can hear you now.
Okay, so I said,
Prosper, how are you?
So what I said is there are things you do to know whether there is a Q wave is pathological or not. There are telltale signs you can use to check that. One, any Q wave that appear in contiguous leads. Maybe you see a Q wave in lead 2, lead 3, and AVF. It indicates there was an impaction in inferior wall in the first. Or you have a Q wave that is deeper than 1 millimeter. So once a Q wave is more than 2 millimeters, 2 millimeters, that is 2 small boxes, is also a pathological Q wave. Or any Q wave that is 25% of the preceding R wave. So when you take the amplitude of the preceding of the subsequent R wave, you take the amplitude of the subsequent R wave, maybe the amplitude of subsequent R wave is 8 millimeter, and your Q wave is 3 millimeter. That is more than 25% of that. So it's a pathological Q wave. So other Q waves that do not meet this criteria are usually non-pathological in nature and can be seen even in normal LVH. So people with LVH can have Q wave that is non-pathological. Yes, Q wave can be seen in non-pathological setting other than MI. Okay, have I answered the questions?
Yes, sir. The second question, sir, on asystole.
Okay, sorry. I actually forgotten. Okay, asystole. Asystole is one of the fatal arrhythmia that usually indicates a non-shockable cardiac arrest rhythm. It's one of the causes of non-shockable cardiac arrest. It's associated with a serious catastrophe, usually in individual with cardiac arrest. So when somebody has a cardiac arrest, what you usually do, you quickly run an ECG. So on ECG, if you have absence of activity for over 3 seconds, so you have ECG, then you have absence, mainly pulse isoelectric line outstretched for more than 3 seconds. That is what you call an asystole on EKG, and it's one of the markers of ventricular arrhythmias. We said if you see it, it's one of the non-shockable rhythm. It's one of the non-shockable rhythm that you may not be able to discuss, that you may not be able to reverse with defibrillation. So even if you are doing a CPR for a patient with asystole, you will not be able to reverse it using a shock. You have to continue until they develop a spontaneous resolution, then you can be able to tell it. So most of the time, an asystole is just a flat line that is more than 3 seconds on ECG. So you're having an ECG with the rhythm, normal rhythm. You're having an ECG with the normal rhythm. You're having an ECG with the normal rhythm. Then you developed a flat line, a stoppage in conduction of the heart by more than 3 seconds. That is what you call an asystole on EKG. And it means the heart is not pumping at all. It's very catastrophic and require prompt recognition and intervention. So I encourage most of you, because of these dangerous arrhythmias that people can slump at the market, in shopping malls, by the roadside, filling stations, banks, and you all should at least obtain your basic life support training, and you should be able to provide a life-saving skill for the patient that will develop issues like asystole. All right, so any other question?
Yes, sir.
Okay.
Sir, my question is, what are the key ECG features that we can use to differentiate between atrial fibrillation and atrial flutter?
Okay, so this was handled in the previous webinar series, but just to make a quick review, atrial fibrillation and atrial flutter, they are both supraventricular tachycardias. They are also called atrial tachyarrhythmias, meaning the atrium, the problem is on the atrium, not on the ventricle. So the atrium is beating fast. For those with flutter, sorry, I don't have the ECG tracings on this on this particular slide. Maybe if you refer, I'll just give you the theoreticals. Maybe if you refer back to the previous webinar, is there.
Okay.
For those with flutter, what they have is they have fairly regular RR interval with sawtooth appearance. You know, a saw that they used to cut wood, fly wood, cut trees. If you look at the tooth, you will see projections of those tooth. So that is how it appears. That is what you call floater waves. Floater waves. So they have sawtooth appearance around the P waves. And you have multiple of them, 2 or 3, before you can see QRS complex, meaning that you must have 2, 3 P wave, that is 8, because the atria is discharging at high rate, around 180, 200, 250 beats per minute, before you can have conduction. So the AV knot is there regulating the atrial discharge. That is for the floater waves. Well, for the fibrillation, completely the P waves is absent. You don't see P waves. And the R to R distance or interval is not regular. Here you can see 9 small box, the other one can give 15 small box, the other one can give 11 small box, no particular pattern. So when you see absent P wave with irregular RR interval, that is atrial fibrillation. And the beat can be in excess of 200, 300, 350 and above. So that is it. So in atrial flutter, R to R interval is fairly regular, and they have P waves that are merged, giving a sawtooth appearance, usually multiple before you want QRS complex. That is the flutter waves. While in fibrillation, you don't have P waves in most cases, and the R to R interval is not regular. Any other question?
Okay, thank you very much.
Yes, sir. Sir, I have a question, sir.
Okay.
My name is Abubakar Bello Alhaji from Usman Danfodio University, Sokoto. So my question is not is mainly not on today's lecture. It has been taken and it is the previous lecture on the reading disorders. So I was reading through the slide. I reached a place where I saw sinus arrest and sinoatrial exit block. So I couldn't differentiate between them. Like the explanation there, I couldn't get it. If you can explain,
All right.
like
I
the
don't
difference
think those ones are for undergraduate anyway. There is sinus force, sinus arrest, sinus exit block. They all have to do with P to P interval instead of R to R interval. There are a lot of things you consider. What it just tell you in a simple language. In all those sinus force, sinus arrest, sinus exit block, you have failure of SA nodes as primary pacemaker of the heart. So there is no discharge for a time being. How to differentiate them, please, is for advanced class. Thank you. All right, so in the absence of further questions and comments, I would like to once again thank the organizers of this webinar series. Thank all the participants that spare their time from different countries, including our country, to participate in this webinar series. I will encourage all of you to practice more and more on all the webinar series you had. You are also encouraged to support this community of internal medicine interest group for more webinars. We are always ready to support you people to put our best. We are also learning as we are teaching you. So all of us are learning from each other. I'm very happy to be in your midst this evening. Thank you very much. I hope to be part of you in the nearest future again. Thank you, Dr. Stanley. Great Dr. Governor Furawara for us.
Dr. Fahad, thank you very much.
All right. Thank you very much, Dr. Fahad.
Thank you so much, sir. Thank you so much.
Sir,
Right,
thank you very much, sir. Can you drop your LinkedIn account for us so that we can learn more?
Thank you very much, sir.
Alamin, I will cut your neck.
Thank you very much, sir. I'll come and see you too, sir.
All right, guys.
Thank you, sir.
So much. Thank you so
Thank
much
you
for
all.
this session.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you. I will come and see you too, sir. Till I
All
come,
right,
sir.
so you can come. You are free to come.
So much.
I'll come to office too, sir. Thank you, sir.
Don't worry, Dr. Yahaya has my email. He can share with you. You can reach out to me.
All right, guys. I
We'll
have
come
an
and see you in office. We'll come and see you in
Fine.
office, sir. Thank you,
Sir,
sir.
they should meet me. I will give them. I can give them everything about
Good day,
You
sir.
are
the email.
malignant.
This is Ali Haruna. Good day,
You are
sir.
in
Thank you,
Abuja.
sir.
All right, guys. Thank you so much for being part of the session up to this final day. Thank you for your time, for your engagement, and for your enthusiasm. We appreciate. Please note that the post-test link will be in the group chat and it will be available for 72 hours. I would also like to extend a very huge thank you to the organizers, to the president, for their dedication behind the scenes in organizing and coordinating this program. Thank you so much. And to Dr. Fahad Lawa, our distinguished guest, thank you so much for your clarity, for your time and effort, and for coming on board. Thanks, everyone. Please remember to sign the attendance. The link is in the chat box. And also don't forget about the post-test link as well. Thank you so much, everybody.
Sir, I want to ask a question. When the post-test is going to take place?
The post-test link is going to be dropped in the group chat and it's going to be available for 72 hours. So just
Okay,
try.
72 hours. It means you can do it even tomorrow.
Yeah, for 72 hours,
Oh,
yes.
okay, thank you, sir.
Yeah.